All right, now we're going to talk about Module H, the musculoskeletal system. Okay, so the musculoskeletal system provides structure and movement for our body. It also protects and gives our body shape. And of course, it's made up of muscles and skeleton, or muscles and bone, I should say. Muscles, in our body, we have over 600 muscles that are made up of elastic tissue. Some are connected to bones by tendons, which we'll talk about a little bit more in a minute here. But what you need to know is that our muscles can be involuntary or voluntary. Involuntary muscles work automatically, so we don't control them. I think the best example of that is probably our heart muscle, right? The cardiac muscle. We don't have to tell that muscle to work. These muscles are smooth. They control the action of organs such as the stomach, intestines, blood vessels, etc. Whereas voluntary muscles can be controlled, and these are skeletal muscles. They are attached to the skeleton and include your arm, your legs. These are striated muscles. So I tell my arm to outstretch, right? I have control over that. Muscles power the movement of the skeleton. The tendons that connect muscles to bone and move the bones when the muscles are contracted or shortened. They also give the body form or posture, and muscles produce the majority of our body heat. When our muscles contract, food is burned for energy, and that's what produces the heat. So the more muscle activity, the greater amount of heat, which is why when we're exercising or working out, our body temperature rises. Or another good example is when we're cold. That's why we start to shiver, because we have those rapid muscle contractions trying to produce as much heat as possible to raise our body temperature. Now, we have skeletons and bones, right? So our skeleton, we have 206 bones. They are the framework of our body. On the outside, our bones are hard and rigid and contain blood vessels. The inside of our bones are soft and spongy. That's the bone marrow. And that's where blood cells are made and stored. Bones are connected to other bones by ligaments, and as mentioned, they're connected to muscles by tendons. So let's talk a little bit more about that. We already mentioned that the skeleton is the framework of the body, but it also protects our organs. It allows our body to move. It stores calcium in addition to making and storing those blood cells in the marrow, like we mentioned. Joints. Joints, as we said, are points where bones meet. They are made up of connective tissue called cartilage that cushions the bones and keeps them from rubbing together, right on top of each other. When you start to have things like that, like in this image here, you can see if they're bone on bone, that's when you see people with a lot of pain, like in the knees. They may need a knee replacement. So we also have a synovial membrane that lines these joints and secretes a synovial fluid. This fluid is what acts as a lubricant so that these joints are able to move smoothly against each other. So joints can be movable, slightly movable, or immovable. Slightly movable would be like your backbone, right? We can bend forward. We can essentially bend forward all the way to the ground, right? Touch the ground or touch our toes, but we can only move it a certain extent backwards. They can be movable like our ankle, which we can fully rotate 360 degrees, or immovable like the skull. There are different types of joints as well. So ball and socket, hinge, and pivot. An example of a ball and socket would be our hips or our shoulders. These types of joints allow movement in all directions, and it's made up of a rounded end of one bone that's fitted into the hollow end of another bone. Hinge joints allow for movement in one direction, like our elbow or knee, and pivot joints allow for turning from side to side, like where our skull is connected to our spine. When everything is functioning properly, we expect to be able to move and perform routine movements of activities of daily living, full range of motion and exercises bilaterally, which just means equally on both sides without pain. And we're going to talk specifically about some terms you want to be familiar with when we're referring to and talking about movement. So there's abduction and adduction. Abduction is moving a part of the body away from the center, so like moving your arm or leg out to the side. Adduction is taking something in towards the body. And I remember that because of I'm adding something to my body. There's extension and flexion. Extension is extending away from the body without pain. Flexion, bringing it in close. There's extension of the leg, just like with the arm, extending it down. And flexion, bringing it up towards. So flexing, you think of flexing a muscle. I think I might have misspoke when I said that a second ago. When you flex, I don't like the image, maybe that's what it is. When you flex your arm, you're bringing it in towards, right? So just like in this picture of the leg, you're flexing the leg up towards your body. There's also pronation and supination. When we say something's prone, which we've talked about in previous lectures, that's when something's on its belly. When something is supine, it's on its back. Two other terms you want to be familiar with, dorsi and plantar flexion. The way I remember these, well, dorsiflexion is pointing your toe up towards your head. Plantar flexion is like you're planting something in the ground. And then there's also something called opposition. You want to be able to do this without pain as well. Opposition is actually just being able to touch your thumb to each of the other fingers. So when we have normal findings, these can be done, again, bilaterally on each side of the body without pain or restriction of range of movement. All right, so as we age, our muscles weaken and lose some of their tone. Our bones lose density and become more brittle. We also have slower muscle and nerve interaction, and our joints tend to become a little more stiff, and less flexible. This is why sometimes we do have some pain and decreased range of motion and flexibility as we age. We also tend to see a height decrease from about 1 to 2 inches between the ages of 20 and 70 is when this happens. As we age, we have slower recovery from position changes and sudden movement. Sometimes we'll have some pain or discomfort with movement. And as we age, our reaction time, our movement speed, our agility, and endurance decrease. We also have poorer response to stimuli. These things all change gradually as we age, but when we see the following things, these are considered more of a variation from the normal and something we want to make sure is brought to the attention of a nurse. If we have a resident or patient who has reported a history of repeated falls, that's important. If we have a resident or patient who has difficulty with holding or lifting an object, if we notice a loss of muscle strength or tone, an increased and generalized weakness or tiredness, bruising, or slow or unsteady movements, these are all things we want to report. In addition, if we see white, shiny, red, or warm areas over a joint, that could be a sign of arthritis, along with complaints of pain in those areas. Any swelling, redness, complaints with movement, or if the joints become unable to move. These are all things that we want to report. I mentioned arthritis, so let's talk a little bit about that, because that's a common condition that we're going to see. Arthritis is inflammation or swelling of the joints that causes stiffness, pain, and decreased mobility. There are two common types of arthritis. There's osteoarthritis and rheumatoid arthritis. Osteoarthritis is a degenerative, so over time, joint disease. It affects the elderly and may occur with aging or with joint injury. It usually occurs to the weight-bearing joints like the hips and the knees, but it can occur in the fingers, thumbs, and spine. Usually they're going to have pain and stiffness, and it does tend to increase, you may have heard this before, in damp, cold weather. Rheumatoid arthritis, on the other hand, can affect anyone at any age, and it usually starts with the smaller joints and then it progresses to the larger ones. The joints become red, swollen, very painful. These patients can also experience fever, tiredness, weight loss, and have severe and painful deformities that eventually completely restrict movement. Rheumatoid arthritis differs from osteoarthritis in that rheumatoid is considered an autoimmune disease when the normal tissue is attacked by the immune system. Our role when someone has an arthritis is to continue to encourage activity, follow the care plan, give safety rails can be helpful, give canes, make sure they're using assistive or adaptive devices. We still want to encourage that independence by assisting with the use of any devices that have been given, assisting with clothing or feeding as necessary, but again, encourage that independence. help maintain self-esteem, and watch for or report signs and symptoms of stomach upset or heartburn. And why we say that, because a lot of these medications that someone might be on for arthritis can cause stomach upset or heartburn, and we want to make sure we're reporting those. Osteoporosis, I'm going to talk a little bit about that. This is another condition that we may seem different than osteoarthritis. This is osteoporosis. This is when bones lose density, causing them to become more porous, as you can see in this picture, and brittle, which makes them easier to break. This can be caused by a lack of calcium in the diet, a lack of regular exercise, decreases in mobility. As our female hormones decrease as we age, it can cause osteoporosis. Some signs that someone may have osteoporosis is low back pain, a stooped posture, becoming shorter, or broken bones. As nurse aides, we can aid in preventing or slowing the progress of osteoporosis by encouraging activity, encouraging exercise, and helping the resident to move carefully. Fractures. Fractures are broken bones caused by accident or by the osteoporosis we just spoke of. Fractures can be closed, where this bone does not break through the skin, or open. Open fractures are also called compound fractures, and that's when the bone actually comes through the skin. Some of the most common sites of fractures are the arms, wrists, elbows, legs, and hips. The goal is always to put that bone back into alignment so that it can heal properly. When a bone is put back into alignment, bone tissue grows and fuses that area together, but it must be allowed to do that by keeping that area immobilized. That's why we see casts. Signs of a broken bone: pain, swelling, bruising, or limited mobility. And our role as nurse aides is to prevent. That's the big thing first, is prevent a fall, prevent a broken bone from even happening. If someone does have a broken bone, elevation of that extremity is really important to help with decrease in swelling and decrease in pain. We also always want to observe for circulation to that extremity. So if someone broke an ankle, for example, we want to make note: do those toes look and feel like they have good circulation? Is the resident complaining of numbness or pain? If they're doing that, we need to report that in case we're not having good circulation to that extremity. We can also report any irritation or pressure from any casts and make sure that that is addressed as well. Hip fractures. This is a break in the hip bone. This is a very serious condition that requires often months of recovery. Older resident heals more slowly too, and often complications can occur from a hip fracture. A lot of secondary illness and disability occurs when the older adult breaks a hip. This can result from falling, of course, or a broken hip due to weakened bones that cause a fall. Most hip fractures will require surgery and total hip replacement. The goals will, after surgery, are to care for that incision site, make sure we prevent infection, slowly regaining strength in that hip through physical therapy and exercises. The ultimate goal, of course, is to regain mobility, gait, and endurance. So again, we're wanting to prevent falls from happening in the first place to hopefully prevent any kind of hip fractures. After surgery and during rehabilitation, we're following any care plan. When someone has a hip fracture and they're recovering, we're going to have specific weight-bearing limitations that, as nurse aides, that's going to be really super important that we follow per the care plan. Someone might start out as non-weight bearing, then go to partial, and then full weight bearing, and we need to make sure that we pay attention to that. We do not want to perform range of motion until we are specifically directed to do so as well. Certain motions of the leg and lower extremity, if we perform those, can really mess up that fresh hip surgery. A lot of times we're using those abduction pillows. We looked at that in a previous lecture when we talked about assistive devices. These go between the legs to immobilize and position the hips appropriately while healing is taking place. If we notice, or if we get reports from the patient of any redness, drainage, bleeding, increased pain, or numbness or tingling, any swelling, we definitely want to make sure that we are reporting this right away. Total knee replacement is another procedure we may come across. This is the surgical replacement of a knee with a prosthesis. A prosthesis, as we've talked about before, is a device that replaces a body part that was either missing or deformed. Total knee replacements are performed to relieve pain and restore mobility from knees that were damaged by either arthritis or injury. Post-op care is similar to a hip replacement, though the residents do tend to have greater ability to do self-care with with a knee replacement versus a hip replacement. Goals after goals after a knee replacement are to prevent blood clots. We might have the compression hose to put on. Sometimes certain machines are used to help with mobility. We want to make sure that they're doing the range of motion exercises to promote healing, to decrease stiffness. So we're just following the care plan regarding any kind of mobility. We're encouraging fluids. We're encouraging patients to become more independent. And of course, reporting any signs of pain, redness, swelling, heat, or tenderness. Amputation, that's the surgical removal of some or all of a body part. This can occur the arms, hand, leg, foot. This happens, it could be related to a disease like diabetes or an accidental amputation. We talked a little bit about the phantom pain in a previous lecture, in the pain lecture. This is when a person experiences pain in the area that has been amputated. We do not ignore this pain. This could be possibly as a result from damaged nerve endings. So we are reporting this and treating this as we would any other report of pain. So we're following any kind of care plan in regards to the amputation. We want to provide assistance with activities of daily living, provide support for that phantom pain, and reporting to the nurse any changes in range of motion, in pain and discomfort, etc. We mentioned contractures in a previous lecture as well. A contracture is when a muscle or tendon shortens, freezes, and becomes inflexible. This is a permanent disability. Once a contracture has happened, we're not going to be able to, if it's in the arm, for example, we won't be able to straighten that arm back out again. So when we're talking about contractures, and we'll mention this again in a second, prevention is key. Muscle atrophy, that's when a muscle wastes away, it decreases in size and becomes weak from disuse. This can happen for a variety of reasons, but a good example is you get a broken wrist, you have a cast for 6 weeks, you take that cast off, you compare your two arms, one arm is super skinny and weak, the other is, normal to what you were before. So in those cases, we can regain that muscle strength. But with muscle atrophy as well, prevention. These are key and critical for preventing contractures and muscle atrophy. In general, when we're talking about the musculoskeletal system, the key word is prevention. Most falls are preventable in the long-term care facility. Always answer call lights immediately, keep pathways clear. If anything is spilt, clean it up. Keep walkers and canes within reach of your resident. If they have any kind of prosthetic or assistive device, make sure it's being used correctly. Non-skid footwear is really important. And we always want to encourage regular movement, activity, self-care, and exercise. And that might just be light exercise and range of motion, or it might be walking around in the halls. But we want to encourage that exercise and activity as well. And that concludes the musculoskeletal system.